Welcome everybody to the NBCC Code of Ethics Update 2023. This is part 4 of 8. And again, I know it's 2024, but the Ethics Code was released in 2023. I am your host, Dr. Dawn-Elise Snipes. Today, we're going to continue reviewing the 2023 NBCC Code of Ethics point by point, talking about treatment planning, documentation, ability to consent and incapacity, counselor educators, and supervision. Treatment planning is one of those things that I really harp on with my staff and my supervisees, because treatment planning, especially if you do it with the client in concert. You don't do it for the client and hand it to them and say, sign this. They don't learn how to set goals that way. They don't learn how to identify a big goal and the sub-objectives and how to set SMART goals. So doing a treatment plan with them can be a very therapeutic endeavor. The treatment plan also tells providers, or not providers, but payors, what you're going to work on. And if you receive state funding or Medicaid funding, you probably have certain treatment plan goals that are required to be in there. Like in substance abuse, we were required to have, recovery from substance misuse or abstinence in the case of our program as a goal. When for TANF funding, there were other goals that we had to set for the individual based on the TANF program. And if we got those funds, they said we had to work on these things. Now that set the overarching goal. How are you going to become financially stable? Okay, well, that'll differ for each individual. And that's when you sit down and you ask them, what is it that you need to do? Some people may have a job that they are able to go back to, or they're still in, and that's not a problem. They need to get promoted in order to become more financially stable. Some people may have no work history, so we need to help them find the American Job Center and figure out what they need to do in order to access assistance with identifying skills, writing resumes. A lot of people also qualify for WIOA funding, which is Workforce Innovation and Opportunity Act funding. So people who, for example, want to learn how to be long-haul truck drivers or substance abuse counselors would qualify for or could qualify for WIOA funding. But anyway, that is just sort of a side point to recognizing that you can have some general overarching goals that are the goals of your program or the goals of your funder, but individualizing those goals to meet the needs of the individual, imagine that, is an ethical imperative. We are not helping them. We are not being beneficent. We are not being faithful or using fidelity if we are doing things for them. We are not promoting autonomy if we write the treatment plan for them, hand it to them, and say, here, sign this. So it is important to recognize that. It's also important to consult with your client on a regular basis. If you accept certain types of funding, like state funding or Medicaid funding, a lot of times in our treatment plan notes, we have to identify in the note, the progress note, which goals and which objectives we worked on each session. So the treatment plan guides treatment, and sometimes it needs to be modified, and that's okay. And that's when we check in with the client and we say, it seems like you're stuck here, or, oh my gosh, you had this other thing happen. Maybe we need to pivot and focus on a different goal right now. So according to the ethics, counselors shall update and modify the client's record throughout the counseling relationship when changes occur in the treatment plan, including changes relating to goals, roles, techniques, and diagnoses. If someone experiences a trauma while you are working with them, then they may end up with a acute stress diagnosis. Or if you're working with them for a while, it may develop into a PTSD diagnosis. Hopefully not, since you're working with them in that acute phase. But if it does, we need to change. Sometimes their life circumstances will change. And for example, maybe they didn't qualify for certain types of funding before, but now they do. And we need to add treatment plan goals. It's also important not to overwhelm people, though, because if they think they've got 15 goals they've got to accomplish, that's overwhelming for me to even think about. And I'm not in recovery. I'm not trying to heal from addiction or major depressive disorder or generalized anxiety. Thinking about what is a reasonable number of goals. Now with TANF, we had to have 3, and then we generally had 1 for substance abuse. So 4, and definitely no more than 5 at a time, unless there is some outstanding circumstance that you need to put in there. But the more goals you have, the more detailed the treatment plan needs to be to help the person know when they're supposed to do what and walk through it. Counselors shall obtain clients' written approval for such changes. And as I mentioned earlier, don't just hand it to them and say, here's your treatment plan, sign this, this is what we're doing. That does not teach them how to set goals. I know I already said this, but this is one of my soapboxes. Drives me absolutely batty when either a treatment plan is not done at all, and it's just, hey, let's meet and we'll talk about the problem du jour, or when a treatment plan is done by the therapist for the client. That's enabling at best. You're not teaching them how to start solving their own problems and setting their own goals. So we do owe them the opportunity to learn those skills. Counselors shall clearly identify in writing the primary client in the record and those individuals who are receiving related professional services in connection with such client relationship. Obviously, this applies more to family situations. If you are seeing Jim Bob and he is your primary client, you're going to identify that in the record. And Jim Bob is the one who has access to those notes. If you're seeing a couple, for example, and you're seeing them for couple sessions and you're seeing them for individual sessions, it's important to differentiate. Jim Bob is going to have his file. Sally Sue's going to have her file, and then there's going to be a joint session file. I find it easiest to do it that way instead of trying to have partitions in the chart for Jim Bob's notes, Sally Sue's notes, and the couple therapy notes. Whatever works for you, but it is important to know who is the primary client, because this is the one to whom you are responsible for maintaining confidentiality and HIPAA and all that other stuff. You're not going to take something that you learn in confidence in an individual session with Jim Bob and blurt it out in the couple session. If Jim Bob decides to bring it up, that's on him. But you can't violate that confidentiality. In the context of couple, family, or group counseling, the counselor shall not reveal any individual client's confidences to others without the prior permission of that individual. A lot of times when I work with couples and we talk about something in individual counseling that really needs to be brought up and discussed between the two of them, I still don't bring it up. I will say, Jim Bob, in our session, we had discussed a bunch of things and there was some stuff that you wanted to talk over with Sally Sue. Do you feel comfortable approaching that now? And allow Jim Bob to either say yes or no. I'm not going to say, well, an individual, you said you were going to talk about her spending too much time on her phone or whatever the gripe was or concern was. So we do need to recognize that. Same thing is true in group counseling. And I worked in residential for many, many years. And our program, we had 4 hours of group every day. And the individual clients were supposed to get at least 1 hour of individual every week. What you learn in individual can't be brought up in group. If you're talking about addiction, we'll just go with that one, that's easy. If we're talking about addiction issues and in individual, the client shares that they relapsed, you can't go into group and announce that to the group or even bring it up as part of the group process. That's up to the client to bring up to the group and say, hey, y'all, I relapsed. So we do need to be very, very cognizant about that. And it can get sticky because sometimes it's hard to remember what was said in individual, what was said in group, which is why it's really good to often elicit things from clients and allow them the opportunity to either, continue and share or not. But it is something that we do need to be aware of. In residential, it was always unique because, you've got 85 people in the house hanging out together, and sometimes they would tell you something in individual in confidence. Of course, we're going to maintain confidentiality, but then they feel so liberated by sharing it, or maybe they're upset after sharing it and they're trying to get consolation from one of their housemates. They may share it with other people, and then it starts going around like wildfire. Sometimes the client may believe that you broke their confidentiality. So it's important to really be able to walk them through that about who else might have known this if it comes up, in order to help them, number one, feel safe and recognize you're not breaching their confidentiality. And number two, to help them be more mindful of what they're sharing and what the potential consequences are of them sharing with their housemates. In terms of inability to consent, counselors working with minors, incapacitated adults, or other persons unable to give consent shall protect the confidentiality of information received as specified by federal and state laws. Incapacitated adults, if you're talking about somebody who has dementia, if we're talking about somebody who's been declared legally incapacitated and they have a legal guardian. If it's a minor, many times we have special rules we need to undergo in order to protect their confidentiality. Many times we also have special rules, obviously, all y'all know, in order to get permission to provide treatment. That legal guardian may need to sign the informed consent. And I know there are some exceptions for youth in some states deciding that they need to receive services for something. Some states have said, the youth can receive services without parental prior approval. And if you work with youth, you're more familiar with that. The other issue I would bring up, though, if you work in addiction settings, is a lot of times when people come into detox, they are borderline unable to give total consent. They can give consent to admission, but they're not going to be able to do an effective assessment, biopsychosocial assessment, when they are highly, highly intoxicated. So we do want to push that off until we can get a sober consent from them when at all possible. Now, again, when they admit to your facility, if you're in detox, there are certain things that they're going to obviously have to consent to in order to be able to be admitted to the program. But we want to minimize the information that we're trying to get. We want to minimize the especially any of the cognitive sort of work that we're doing until they're more cognitively present, which in detox, most people, when they first show up, they don't want to do their assessment. They feel like crap and they want somebody to help them feel better and somebody to help them through the withdrawals. In all cases, the counselor shall discuss with the client and their legal representative the limits of confidentiality and the rules concerning the release of any information. We owe this to our minor clients as well as to our adult clients, our incapacitated adult clients. We owe it to them to explain to them in a way they can understand, if at all possible, and to explain to their legal guardians what the limitations are, what I'm able to share with you versus what you want to know. You know, I'm not going to be telling you everything that's in my progress notes. You don't need all of that information. I will let you know if Junior is becoming suicidal or homicidal. I will let you know, there are certain things that we are going to let them know. We will let them know about attendance, about participation. There are things we can, but just like when there's a court order that says you can give away this stuff to the court without having a separate court order, you need to have a separate court order for progress notes. And for CFR 42 Part 2 programs, they also require a special release of information for the substance abuse progress notes, which CFR 42 Part 2 differentiates from your run-of-the-mill mental health progress notes. So that's kind of interesting there too. Not everybody will do two notes, a mental health and a substance abuse note, because that also kind of flies in the face of co-occurring treatment. But if you are in a CFR 42 Part 2 program, which means you accept federal funding like Medicaid and Medicare, then it's important to understand that some stuff may need to be redacted from the progress notes, and you'll need to work with your legal counsel on that to figure out, what can I give them? What can't I? Counselors respect and honor the inherent and legal rights of the parents and legal guardians and minors, of minors and incapacitated adults. Obviously, we want to treat them with respect. We want to respect their rights. They are the legal guardian. They are part of this person's family, but we also need to balance that because the identified patient is the juvenile or the adult who is currently incapacitated. As appropriate, the counselor shall collaborate with the parent or legal guardian discussing the role of counseling, the confidential nature of the counseling relationship, and the autonomy of the client as required by the NBCC Code of Ethics, state, and law. Remember, I said earlier, some states allow minors to seek counseling, especially over the age of 14 in most states, allow minors to seek counseling without parental approval. But that is not always the case. So if you work with minors in your state, you need to know what the rules and regulations are. Are there any questions about ability to consent? And for those of you who work with children, specifically juveniles, non-adults, whatever we want to call them, because teenagers, I don't like calling them children, but non-adults, if you have something to share, that's awesome, because I haven't worked with juveniles for over a decade. So honestly, I haven't kept up on the laws and rules regarding when they need permission and when they don't. But Alrighty, so we will continue to move on. Counselors will advise their client of this action, which is talking to their legal guardian, in a manner consistent with the client's level of understanding. Most cases, when working with people who are incapacitated or who are juveniles, it is better, in my ethical opinion, or my opinion on the ethics, I guess, it is better to have the identified patient in the room when you're talking to the legal guardian. That way they know what's being said. They don't feel like, oh, they're talking about me behind my back. And we talked about this, I think, last week or the week before when we talked about documentation and how important it is to recognize, number one, that clients can read any of the documentation in their, or request to read any of the documentation in their file. But also, it can be empowering to the client and destigmatizing to the client to see what is actually in their chart, to see that you're not writing this, this person is, really, really crazy. And we wouldn't obviously use that word. That's why I stumbled on it for a second, because I would never use that word in a progress note ever. But it helps them understand what's being said. And if you're documenting, like I suggested whenever we talked about that, whichever episode, if you're documenting where you say this person meets the criteria for major depressive disorder as evidenced by, that gives them an understanding of how you arrived at that conclusion, which teaches them how to arrive at those conclusions. If it is as evidenced by, your low mood most of the day, as evidenced by fatigue and difficulty concentrating, those symptoms are going to have their own unique causes and interventions for the individual. What's causing one person's fatigue may be hypothyroid or iron deficiency. For other people, it may be they've got sleep apnea. For other people, it may be they've got really crappy sleep hygiene. So we want to look at, we have the diagnosis as evidenced by, these are the symptoms, and then we want to help them figure out what is causing those symptoms. And that can be really, again, really helpful for clients to see sort of your mental process as you're going through it, so they can learn how to do it. We need to make sure it's consistent with their level of understanding. If you're working with an 8-year-old, you're obviously going to approach the situation very different than if you're working with a 28-year-old. Oh, and one other thing about capacity, it's also important if you work with people with dementia or Alzheimer's or any of those dementia category sort of disorders, to recognize that some days they may have better days. They may be more lucid. Some days they may not. You may have to repeat yourself. I prefer to do a little mini informed consent at the beginning of every session with clients to make sure, number one, mental status exam, see how oriented they are to time and place, and make sure that they are wanting to talk to me and consent to talk to me. That's important for me as an individual. Obviously, I'm not recording these things when I'm doing this session, but I'm going to put it in the notes that Jim Bob was oriented ×4 and agreed that he wanted to participate in a counseling session. So now, joint custody can be really sticky. Counselors are encouraged to consult with both parents or other family members prior to the delivery of services in joint custody arrangements to ensure agreement with the treatment planning and record sharing. Since, in most cases, the child is going to need parental approval for counseling. We're going to have that joint custody issue come up sometimes, and it could be mom and dad. It could be mom and grandma, or dad and grandma, or whoever has joint custody, legal custody of the child. Other family members can also be brought in if mom has remarried and dad is remarried and all four people want to get together, or if mom and dad have joint custody but Junior spends the afternoons after school with grandma, we might bring grandma in too. You want to identify who are the primary caregivers in this individual's life, and let's make sure that we're all on the same page, we're all working toward the same goals, and everybody involved understands what can and cannot be shared and with whom. Now, a lot of what we're going to talk about in counselor education and then the supervision section is somewhat redundant to what we talk about with individual clients. So I apologize for that, but I said we're going to go through it point by point. We will. Counselors who act as counselor educators, field placement supervisors, or clinical supervisors shall not engage in in-person or electronic sexual or romantic intimacy with current and former students or supervisees for at least 5 years from the date of the last academic and or supervision contact, whichever is later. So this is not just your teachers. This is your field placement supervisor. When I was at UF, we had a field placement supervisor. I had a clinical supervisor who was at UF. I had a field placement supervisor person, administrative supervisor at the facility I was working at, and I had a clinical supervisor at the place I was working at. If you're engaging in this supervision role in which there is a power dynamic, in which you have the ability to 86 somebody's career, basically, in which they are going to be sharing potential information, it is really important to identify that as a professional relationship for which you should not engage in any sort of sexual or romantic intimacy. Now, obviously, they're very specific here, and they're not talking about necessarily other forms of what we would identify as dual relationships if we were talking about a client. You may end up having a clinician who you provide clinical supervision to for their 3 years or whatever, and then they come and work at your agency. That's not a sexual or romantic thing. It's still, kind of on the up and up. If you're going to the same gym or, a lot of things we need to be hypervigilant about with clients, we don't have to be as vigilant about with supervisees, with the exception of this one caveat. In my experience, it is, how shall I say this, not uncommon for professors, counselor educators, even ones who aren't providing clinical supervision, like, for example, your committee chairs. If you're writing a dissertation or a thesis, it is not uncommon for committee chairs to start dating or engaging in a romantic relationship with their students. And that's a huge no-no. That's just a huge no-no. So anyhow, I've seen it happen. And well, let's talk about that for a second. What potential harm could that cause if you and your committee chair suddenly got into a sort of romantic relationship? And I am going to turn on everybody's microphone for a minute. So if you want to turn off your microphone or turn on your microphone and answer, you can, or you can just type in the chat window what your thoughts are.
I'll say that possibly like it places a power well, there's already like a power thing there, but then it actually unbalances it, because now the student also has power, the supervisor has power, and then you have that struggle of power, which then you lose focus of like what the purpose of the relationship was in the first place. Then
Uh,
it can become really, really nasty and complicated.
And that's a good point. The student now can potentially claim sexual harassment. I hadn't even thought of that. In our in the experiences I have had, it also caused disruption in the clinical cohort, because people started feeling like, well, so-and-so is the favorite and so-and-so can get away with anything. Just like you would see in a family. I mean, it's just the way it is. Our cohorts tended to be 8 to 12 people. So anything that was going on ended up usually becoming apparent to everybody. And that can create, number one, a lot of drama, but it can also, as you pointed out, create challenges for the educator, both legal, ethical, and just even doing their administrative, doing their job. If you are in a romantic relationship with a supervisee or a student, and you recognize that, hey, this person is not cut out to be doing this, it's a lot harder to tell them, hey, you've been in graduate school for 2 years, but yeah, I'm not going to promote you any further if you're in a romantic relationship. So it's harder to do your job. And I think, Nichelle, you alluded to a lot of that. So anybody else have any thoughts about, when we think about beneficence, is it doing what's in the best interest of our students if we're doing that? And then non-malfeasance, we just talked about that one. Fidelity. Are we able to faithfully provide supervision and corrective feedback and whatever we need to do if we're in this sort of relationship? Justice. Do other people in the program feel like they're being short-sighted or short-changed because so-and-so is getting all of the professor's time? So there's a lot of things that we can look at. And you're right, Leslie. Impaired judgment leading to biased decision-making can also be important to consider. If I'm supervising somebody and I'm also in a relationship with them, and I know that they've got some stuff going on in their personal life, and I'm trying to be compassionate and supportive in our romantic relationship, I may make excuses or overlook some of the things that they're doing professionally, because we have that imbalance in our relationship. And it may not be intentional. I may just be giving them a pass for not getting their notes done, or giving them a pass for not finishing their paper on time, because I know that they've got this thing going on. So yes, we can certainly make biased decisions, and just brainstorming biased decisions. When you're grading papers, if you don't anonymize when you grade papers, you could inadvertently score the person that you're in a relationship with higher than other people, or overlook mistakes in their work that you are marking other people down for. The number of years that the professor, counselor, educator should wait to have a relationship with a past student is 5 years. Yes. So with current and former students or supervisees for at least 5 years from the date of the last academic and or supervision contact, whichever is later. So that's a big one. And I would be interested if you want to answer in the chat, how many of you can think of instances in your graduate program in which a professor has violated this. And it's certainly important to let people know, let your students and your supervisees know what the boundaries are of that relationship, so they understand what you're doing. Okay. Counselors who provide clinical supervision shall obtain appropriate training, including continuing education concerning current clinical trends, in order to meet the needs of their supervisees and their clients they serve. Now, this is another one that's a little weird. I don't know any other word to say it. First part, we should get appropriate training on providing clinical supervision. Well, yes. And I teach the supervision class. I teach multiple different supervision classes of varying lengths. And there are a lot of nuances that happen in supervision. Just like in therapy, there's a period of building up a rapport and a relationship. If you're doing group supervision, you go through the same process of forming, storming, norming, performing, and ending. I don't remember what the other ing is, but there's a process that you've got to go through. And a lot of people don't even recognize it. It's like, okay, this person showed up. They're now my supervisee because my boss said so, and blah. A lot of times in community behavioral health, at least, hopefully this doesn't happen as much in private practice where you're charging people for supervision. In community behavioral health, when people are getting supervision as part of their job, and I'm not saying this is right, I'm just saying it is, a lot of times they don't end up with a supervision plan. They don't end up with the informed consent and stuff they need, which is concerning. And we're going to talk about that a little bit more in a minute. It also says we need to get continuing education concerning current clinical trends in order to meet the needs of supervisees. So what does this mean? What's a current clinical trend? There's not going to be a whole lot of change in the way we provide supervision. So what are these trends that we need to be aware of? In substance abuse, being aware of the different substances that are being used in your area. When this will tell you how long ago I started working in substance abuse, spice became a thing. The synthetic marijuana wasn't a thing until I'd been working in community behavioral health for a couple of years. So understanding these new things that you're going to be seeing in your clinic. Again, back in the day, before medication-assisted therapy became well accepted and well known and prevalent, nobody knew anything about that. So helping my clinicians understand, even if they weren't in postmaster supervision, but helping the clinicians that were working under me understand the function of medication-assisted therapy and different issues they needed to be aware of when working with those clients is important. In terms of behavioral health, current clinical trends, there's been a shift toward gender-affirming care. What does that mean? What does that look like? How do we help supervisees implement this or provide this sort of service? Trauma-informed care is a buzzword. Back, again, a couple decades ago, motivational interviewing was a current clinical trend. And it was important for supervisees to be knowledgeable about it, not only in order to provide good quality services to the clients we were serving, but so we were developing well-rounded effective clinicians that would either end up going into private practice or working somewhere else. So we want to make sure that as clinical trends come up, we are keeping supervisees aware of those things, aware of the resources, aware of the new tools that come out. When DBT was first released, obviously that was some groundbreaking work. And I think it's really important for clinicians to be aware. EMDR, it's another thing. Not everybody is going to get certified in it, but at least making sure that they're aware that it is out there, and it can be used as an adjunct to the therapy they're doing with the client if appropriate. So this helps supervisees become more effective and provide better training to the clients that they serve. Think about when you were going through clinical supervision for those 2-3 years, what clinical trends came to light? What new techniques, approaches, or again, therapeutic issues came to light? The Surgeon General, not too long ago, declared loneliness as a public health emergency. Now, that's not diagnosable in the DSM, but it is a current clinical trend. A lot of people are feeling very isolated and very fearful of interacting with other people. Counselors providing supervision shall provide accurate written information to the supervisees. Now, this is, again, one of the things that, unfortunately, in my experience, rarely gets done. The counselor's credentials. Obviously, you're going to be getting supervision from somebody who is licensed, but what is their license in? The process of supervision. This isn't counseling. This is supervision. What's the difference? Did anybody sit down with you when you were beginning your postmaster supervision or even during your master's program? Did anybody sit down with you and discuss the purpose and the process of supervision? Well, excellent, Leslie. Sounds like you were in a great place. And Amanda, Michelle, awesome. Cindy? All right, go FSU. I'll give you that. Christina, it was just a general overview. That's what a lot of people get. It's like, hi, I'm your supervisor. I'm licensed. Give me your paperwork. We're going to meet once a week. Blah. Oh, Neil got none. That's unfortunate. And Teresa got none. Yeah. So we have a lot of people that didn't provide informed consent. I mean, think about it. You are entering into this relationship that could potentially affect your career and the rest of your life, and the person is not giving you the opportunity to provide informed consent. So that's why it's important. Help them know what they're getting into. My style of supervision is different from a lot of people because I do require a lot of interaction and input with my supervisees. They are not going to come in and pick one client they worked with last week and we're going to focus on that for the entire hour and that's going to be it. That's not how I work, because as the supervisor, I am responsible for every single person on their caseload. So anyway, the counselor's credentials, the process of supervision. What is this going to look like? What's expected when you show up for your supervision session? How often are we going to meet? How often is it going to be individual versus group? What do we do if one of us can't make a meeting? You have to have a certain number of hours. Do we make up that hour the next week? How does that work? The conditions of supervision. I will be your supervisor as long as you are whatever your conditions are. Supervision goals. Now, there are some overarching goals that we have to be able to make sure that supervisees can achieve, like completing an assessment, completing their documentation, making referrals, developing rapport. There's a lot of things in there. And if you're an addiction counselor, you can go to the TAP 21, which identifies the addiction counselor competencies. But ultimately, it's divided among 8 different domains, and we need to provide at least for addiction counselors, we provide at least 10 hours of supervision in each of the 8 domains. And then, other supervision to make up all the hours that we need to do. But we need to make sure that we're not hitting every domain to make sure that they are fully developed and competent in each of those. We need to talk about case management procedures. How are we going to handle each of these cases? And again, for me, we go through everybody each week. I want to hear a 1 or 2 sentence status update on everybody on your caseload, and then we'll identify 1 or 2 cases that we're going to review. And case management supervision goals, I don't know, somewhere in there, we're also identifying how we are going to supervise. Am I going to go to your clinic and look through a one-way mirror or a camera? Or are you expected to make video recordings and we'll watch them together? How does that work? We want to go over confidentiality and its limits. And that includes confidentiality for the supervisee. For example, if they are unfortunately become incapacitated and they are not able to do their job, we may have to alert their administrative supervisor or something. So we do need to recognize that. We also need to help them understand that this is, again, not counseling. If you've got drama going on in your life, if you've got something going on, we all have stuff. That's okay. You're not expected to be happy and cheery and perfect all the time. What we're going to talk about in supervision is how that distress is impacting your ability to provide the highest quality services to your clients, and how it might be being triggered a little bit, and what you can do in order to ensure you're providing the best quality services. If you need to process that stuff, if you need counseling, then you're going to process what's going on with your counselor. And it's important we maintain that distinction. We want to talk about appraisal methods. How am I going to assess what's going on? Now, I'm big on rubrics, and for assessments, there are certain things that I'm looking for. Guess what? That key phrase, as evidenced by, is huge in somebody's assessment in their integrative summary. I want to see clear documentation. If you say somebody has major depressive disorder and you don't explain it, then I'm going to wonder where that came from. If you say that they're on Zoloft, but you don't diagnose them with major depressive disorder, that's a problem. Why are they on the Zoloft? I mean, maybe it's for generalized anxiety, maybe it's for something else, but you've got to identify, pull things together from the assessment. So I use a rubric for assessment. I talk with the supervisee. We evaluate the client's progress on their treatment plan goals. And sometimes people are not going to progress as quickly as they would like, or we would like them to, but we do talk about that. And the timing of evaluations. How often is this going to happen? Counselors who provide clinical supervision services shall not have multiple relationships with a supervisee that may interfere with the supervisor's professional judgment or exploit the supervisee. And we kind of talked about that before. If you are somebody's clinical supervisor and administrative supervisor, that gets kind of sticky sometimes, and you need to have clear boundaries between what goes on in clinical supervision and what goes on administratively. When a dual relationship cannot be avoided, the supervisor must discuss risks and benefits with a supervisee prior to engaging in supervision and document this discussion in the supervision records. So thinking about it, and I kind of alluded to this because we're short on time, is being an administrative and clinical supervisor a dual relationship? Is it, in what way could these two things contradict one another? And remember, if you want to, you can turn your microphone on. If you just want to type, then more power to you. Well, glad you made it, Lacey. While y'all are responding, I'll talk about the next point on supervision. Counselors who provide clinical supervision services shall keep accurate records of supervision goals and the supervisee's progress. Again, rubrics are helpful, assessments are helpful, attendance charts are imperative in order to demonstrate to the board when someone was seen, provided supervision, for how long, etc. All supervision-related information shall be treated as confidential, you think, except to prevent serious and foreseeable harm to a client or others, or when legally required to do so by a court or government agency or order. Obviously, if you get a court order that somebody's suing your supervisee, you may have to release information. If you get a court order that information from your supervision sessions is being, for the supervisee's client, is being requested, which I don't think that's ever happened to my knowledge, but it could, then you've got to comply. In terms of the supervisee having a dual relationship administratively and clinically, Michelle points out the supervisee may need to process problems they're having with their administrator concerning patient care and may not feel comfortable doing so. Great point. As an administrative supervisor, I want to see those 30 billable hours every week. I know 30 is just crazy, but that's what we used to require. As an administrative supervisor, those notes need to be done. As a clinical supervisor, I'm concerned about the quality of services being provided and if there are hang-ups, what's going on. And talking about what may be impairing the therapeutic relationship. And for example, if your agency double books people, that can really hurt the therapeutic relationship. And so the supervisee may feel trapped between the clinical supervisor and the administrative supervisor. So that's a great point. Christina says being an administrator can make things difficult in supervision because if there's business metrics that need to be met, that can become a focus of discussion instead of quality counseling information. Again, very true. If I spend the entire hour trying to brainstorm with you how you're going to get your progress notes done on time and how you're going to improve your client show rate, that's not clinical supervision. That's administrative supervision, and the two need to be very separate. And when the counselor talks about things in supervision, also affects their ability to do their job. If the administrative supervisor becomes aware of, for example, something that's triggering the supervisee in session with a client, they may recognize difficulties that they wouldn't recognize otherwise. But all right, excellent points. When a supervisor receives a court or governmental agency order requiring the production of supervision records, the counselor shall make reasonable attempts to promptly notify the supervisee, just like we do with patients. We get the order, we don't automatically go, here you go. We try to notify the patient or the supervisee ahead of time. In cases in which the supervisee is a student in a counselor education program, the supervisor counselor shall release supervision records consistent with the terms of the supervision arrangement with the counselor education program. So you're going to be communicating based on a predetermined arrangement with the site placement person at the university and only providing them the information that they need. Clinical and administrative supervisors shall intervene in situations where a supervisee is impaired or incompetent and potentially placing the clients at risk. For example, if you had a supervisee who decided, hey, EMDR sounds really cool, I think I'm going to try this with my clients. No. That goes back to you need to be appropriately trained and supervised in the techniques that you use. And reading a book on EMDR is not working to meet that criteria. So we do need to be sensitive. The supervisor will notify the supervisee of any concerns and provide recommended or required steps to seek assistance. If the supervisee seems impaired in some way, whether emotionally or physically impaired, and unable to provide the services that they need to provide to the clients, then we need to help them identify an action plan to improve their performance and let them know about the consequences of failure to address those concerns. The supervisor may also take steps to end the supervisee's services to protect the client, who may only resume services after the completion of any recommended or required mediation. And that one's a little bit confusing written in the way it's written. But what they're saying is you can put somebody on a leave of absence from seeing clients if you think that they are unable to provide appropriate quality services, and they can only start seeing clients again once they have met their remediation recommendations. Now, the ethical question that goes along with this is, what do you do with their clients while they're on temporary leave? And making sure that you have some sort of plan for handling that is really important. Making sure that the supervisee, as appropriate, is able to let the clients know, hey, I need to take some time off. And it may not be another session, but making sure that they can do that. Counselors who provide supervision services shall provide supervisees with regular and substantive feedback throughout supervision. So what's substantive feedback? It is feedback that can help them understand what they're doing, the quality of what they're doing, and how to improve it. We want to reinforce the positive. You're doing, this is what I saw in your session, and that was really awesome, and blah. And then this is what I saw in the session, and it looked like this was the consequence. So let's talk about ways to address that. You're giving them substance to work with. You're not just going, yeah, you did fine. No problem. Mark says, while doing an internship in Georgia, a student that was in supervision by a doctoral level person, a phallic dildo he had hanging around his neck fell out of his shirt while in group supervision. As an administrator, the supervisor immediately asked if he had been wearing that around his neck over the last year, and he said yes. She immediately ended his 1-year internship and made him start over and failed him. So the question would be, in applying beneficence, non-malfeasance, fidelity, justice, the supervisor didn't like the fact that he had been wearing that around, but clearly nobody else knew, or we're assuming nobody else knew, or we probably would have heard about it. So was it an appropriate level of reaction to fail him and make him start over again because he was wearing this around his neck? Was it inappropriate? Yeah, because it could fall out and it could offend people. It could traumatize people. It could trigger trauma in people who have been abused. So we do need to be sensitive to that. But y'all, what do you think about what happened? Do you think that was an overreaction or an appropriate reaction to the situation? And I agree, Christina. If the person's working with children, it could theoretically be deemed inappropriate. But again, if it was hidden in the person's shirt the entire time, I don't know. But yes, there's a lot to consider about what was going on with the client, or with the supervisee, and the totality of their work. Is this something that we can address in isolation? Because wearing a dildo around your neck doesn't necessarily mean you're not a good therapist. It shows you've got some poor judgment about some things, probably, but it doesn't necessarily mean you're a bad therapist. And it could be a kink thing. And again, this person was, I don't want to say hiding, but was not displaying it for the world to see. It was something that they were wearing. Like some people will wear a cross or some sort of spiritual emblem underneath their shirts because it's important to them and they want to have that near their heart, but it's not necessarily something they are trying to share with the whole world. But that is a interesting scenario that I can say that I don't think I would have ever come up with. Okay. And Mark adds that this person was from another country. So we also need to potentially consider cultural issues that may have made that appropriate. And I am not, okay, Michelle says the Greeks used this symbol to represent fertility. So, that could have been something that was benign in their mind, but the supervisor reacted strongly to. Thank you for Michelle and Adriana for adding that context as well. And Paula points out that in general, it's poor supervision to do anything immediately. If somebody does something you don't like, acting in the heat of the moment when you're in fight or flight is not when you're going to make your best decisions. Generally, addressing the issue and saying, I'm really concerned about this, and we'll talk about it tomorrow, is a much better approach. Supervisors also need to seek supervision. If that happened to me, I would have been going to my boss and I've been like, Richard, this is a new one. And, it feels like it's inappropriate, but I'm trying to understand the whole picture. Talking to the supervisee. Why were you wearing that around your neck? What was the purpose? What was the point? And if it was a fertility symbol, maybe they were trying to get pregnant or something. And so that could have been something that they were doing that was part of their personal life. It could have been, there are a lot of things it could have been. Excellent discussion on that one. Counselors shall promote the welfare and continued education of supervisees by discussing ethical and legal standards and practices related to counseling. We need to make sure that supervisees are getting their ethics, continuing education, even before they're licensed, making sure that they're staying up to date and aware of issues. Because there actually is a lot of stuff we can cover, the code of ethics aside, that is important for clinical supervision. Counselors who provide clinical supervision services shall establish procedures for responding to crisis situations related to supervisees and the supervisee's clients. These procedures shall be provided both verbally and in writing to the supervisees and potentially the supervisee's clients, and include contact information for an alternative supervisor in the event of the supervisor's absence. So back in the day, we had to have a licensed person on site when we were providing treatment services if we were not licensed ourselves. That was part of the whole supervision thing. We had to have somebody that we could call into the room and go, help me. That's morphed in several states to not being the case. You have to have a supervisor, but if they're available by phone, that's fine. But what if they're supposed to be available by phone and they don't answer? We need to know, a supervisee needs to know, where's my backup? And that's really important. How to identify crises and where's my backup? And how do I reach out for that backup? Do I leave the client alone in the room? Do I pull out my cell phone? How is that going to happen? And I find it useful to work with supervisees by kind of role playing that once or twice early on in supervision and getting them used to a process that's going to work for them. Counselors who provide supervision services to supervisees who are practicing under the supervision of more than one supervisor shall exchange contact information and communicate as appropriate with other supervisors. So if you've got a field placement supervisor and a thesis or program supervisor, there may be people who are needing this other information. Counselors who act as university, field placement, or clinical supervisors shall ensure that supervisees provide accurate information to clients about the supervisee's professional status. They can't claim that they're a counselor unless they're licensed. They need to, because there's rules about using certain titles. They need to make sure that the person knows that they're a counseling intern. And yeah, okay. In terms of consultation, counselors who seek or receive consultation services from another professional shall select qualified professionals who can competently respond to the identified issue of the client, supervisee, and the student, and document the consultation in the relevant client records. So, seeking consultation about how to handle an issue with a supervisee, you document it in the supervisee's record, just like you would if you sought consultation about treating a client. You would document that in the client's record. Counselors who seek consultation shall protect the client's identity and confidential information and unnecessary invasion of privacy by providing only the client information relevant to the discussion. Brief collaborative consultations between a counselor and other professionals are not considered consultations as long as no identifying client information is provided and need not be documented. So that's going to be a judgment call. At which consultations do you need to document? For example, if I walk into my colleague's office and I say, I've been seeing this client for a couple of months now, and he has relapsed at least twice that I know of, and I'm thinking that he probably needs to have a referral up to a higher level of care. What are your thoughts? Something like that, I might not document if I'm just kind of bouncing an idea off somebody. But if I'm going to a counselor, somebody, and consulting with them, and I'm saying, I've got this client issue and I have no idea how to deal with it, or what I'm doing is not working, can you help me figure out a different way? That's going to be a more detailed discussion. Counselors who provide consultative services shall establish a written plan with the professional seeking assistance. This plan shall include the identification of the primary client concern or issue, consultation goals, potential consequences of actions, evaluation, and future steps. Obviously, this is for an ongoing consultation. This is not a one-off where you are going to your boss or your colleague. You wouldn't have that sort of written contract for that. But if you are engaging in ongoing professional supervision because you want to have the benefit of that, then the person with whom you're consulting you want to have that documented. The consultant shall document all this information in the professional's records. Counselors who provide consultative services shall use and provide the consultees accurate information regarding their consultation qualifications and credentials related to the identified concerns or situations, just like you do with clients. Counselors who act as a university field placement or clinical supervisor shall require that supervisees provide the supervisor's name, credentials, and contact information to the supervisee's clients. That's, again, one of those things that's not often done. When you're an intern, letting the client know, hey, I'm an intern, and here is the contact information of my supervisor if you need it. And that really needs to be explicitly done, not just, that my boss is so-and-so, so, whatever, if you need to go see him. That's not okay. We really want to be explicit that, hey, if you want to consult with my supervisor, here's their information. In this session, ran a little over, we're going to talk about treatment. We talked about treatment planning, documentation issues, working with people who have an inability to consent, working with families in joint custody issues, and the issues that arise with clinical supervision and consultation. Are there any questions?